Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Angelini Pharma.
This program is presented by Medscape Education Global.
Hello, I'm Bettina Schmitz. I'm a neurologist with a special interest in epileptology, and I chair a department for neurology at the Vivantes Humboldt Klinikum in Berlin. Welcome to this activity, Avoiding Common Mistakes in Managing Focal Epilepsy. Today I'm joined by my friend and colleague Leigh Sander.
Thank you, Bettina. I'm Leigh Sander. I'm a consultant neurologist and professor of neurology at UCL in London. And my sort of interest, professional interest, specialist interest is in epilepsy.
Epilepsy can be very challenging to manage for epileptologists as well as for general neurologists. We only have 15 minutes today, so we will focus on some common mistakes that can be eliminated easily, particularly in the management of younger adults and older adults with epilepsy. Now, what is a typical scenario where you think mistakes are made specific to younger adults with focal epilepsy?
Well, that's a very interesting area, and we could spend more than 15 minutes here, but there are some scenarios that you see repeated times. One is that there is this concept that teenagers, young adults can have a seizure once, and that's okay. So nothing is done in terms of investigations. I think that that's a big mistake. Seizure is a seizure. The other thing that I think is an issue, and we should be very aware of this, that even a seizure once in a while is one seizure too many. And the concept that, having a few seizures in a year should not be an issue, should not lead to changes of management is a mistake. I think that we should be always aware to make sure that the person in question is completely seizure-free. Talking about this, and this is something we see a lot in young people, is adherence. And adherence is a problem in the population in general, not just in epilepsy. But in epilepsy, it is an issue because often seizures are not there. So what can we do to improve this?
I think you have to look at the patient perspective and the doctor's perspective differently. So for patients, I think it's essential that they understand that anti-seizure medications don't cure epilepsy, they just control seizures. So they only work as long as you take them regularly. And for neurologists, I think it's important to understand that it's extremely difficult to be adherent. So one recommendation from my experience is that you shouldn't ask your patient, do you take your drugs regularly? You should better ask, how often do you forget? And why do you forget? Then you can start discussing aspects which might improve adherence. Do you have specific recommendations?
Yeah, I think that that's very much the case, that you need to have conversation starters. It's important to have a good therapeutic partnership with the patient. One problem is that often people do not tell the doctor they forgot to take the tablets, and this has different consequences which are not always good. So it's important to establish a good relation so the person in question, the patient, won't be afraid to tell you that they forgot to take the tablets. So that's an important point.
Yeah, that's really very, very important. So if you have a patient who has a seizure relapse, you should always consider that this could be related to non-adherence and not necessarily shows that the drug doesn't work.
Absolutely. The commonest reason that people have breakthrough seizures once they're seizure-free is not taking the tablets. And a point that this is often happening is when there's a break of routine. So it's important that we question the patient when this happened. What was happening at the time? Moving houses, starting a new partnership, holidays. There are occasions for breaking routine, non-adherence, seizures, and then you need to make sure that the right measures are taken.
Often patients don't remember that they are not quite adherent. So I think it's useful to really have practical tips. I mean, there are now all these apps which might remind you.
Yep.
And I think it's also good to have really a box for the week. So you don't really, you see whether you've taken your tablet or not. So these are little tricks which might help.
I fully agree with that. The boxes are really make a difference for a number of people. But the other thing is to tell people to always take some extra tablets in case there is a change of plan. They go out clubbing and they decided to take a detour in their way to home. So, you know, if the occasion arises, they will have the tablet to take with them. And also if they travel, to always take some extra in case there is a change, a last minute change of arrangements.
In the hand luggage.
Yes, as well. That's another one that is very important because people will go to places without their luggage and no drugs. So these are important things to put into the mix.
Therapeutic nihilism. That's really a very hot topic recently in epileptology. So what is that about?
Yeah, no, this is really something that it's not a problem seen in other areas, therapeutic nihilism, but it's something relatively new in epilepsy. And this is, there are a number of reasons for that. Of course, some of the drivers for non-taking tablets, not wanting changes, the nihilism, is driven by patients having had bad experience. So they don't want to try something else because, you know, this is going to cause me side effects. But also doctors often do not like to do this because there are some things out there. For instance, the concept that people become drug resistant once they fail two drugs. For many, that will suggest that there's no point in trying the next drug. So, or having some, let's say, very prominent article saying that people won't, the third or fourth or fifth drug won't work. So that creates an incentive to therapeutic nihilism, which is something we should avoid. It's very important that we treat right. So we should give people every chance to become seizure-free, and that will require constant arrangement, management, if they're still having seizures. But we also need sometimes to make sure that doctors understand that this is what at the end they should be providing.
Yeah, I completely agree. I think this is a really neglected topic, but there have been recent studies really showing that both doctors and patients are pessimistic and more afraid that things could become worse instead of hoping for seizure freedom.
Yeah, I agree. And the other thing that sometimes counts, and I have seen this, is that many doctors, particularly not so much epileptologists, but general neurologists, they have this concept that a 50% seizure reduction is a good outcome. So if they see that someone had a decrease in seizures, that is good. So why bother changing? And I think that we need to tell people that the 50% seizure reduction as an outcome is a regulatory outcome. So it's good for the FDA, for the European Drug Agency, but it's not good for our patients because to some extent, 50% reduction of seizures for a would be like asking someone to jump from the 5th floor instead of the 10th floor. So it's very important that we keep fighting for seizure freedom.
Yeah, seizure freedom really makes a huge difference to many aspects, not just driving, but to all other aspects of life, work and social activities. And there are so many treatment choices that we have. So that's really a very, very important message today. Now, what's also important, I think, is that epilepsy is a very individual disorder, and that it's really important to understand what's relevant to your individual patient. And if you choose the optimal drug, I think really looking at what are the preferences of your patient. Side effects of anti-seizure medications are very heterogeneous. They might affect weight, mood, sleep. There are drugs which are safe in pregnancy, others not. So it's really very relevant to match patients' preferences and side effect profiles if you want to make your treatment work. And I also think what is perhaps more important today, that we have so many choices, that we explain to patients that tolerability is important, and it's not just seizure control. So if drugs are not tolerated, we change.
Absolutely, we should have a very low threshold for tolerability issues. And my own sort of is like, would I put up with this? Like I saw a letter from a neurologist saying this patient is completely seizure-free, but he has to put up with 1 hour of diplopia every morning. I wouldn't do that. Probably neurologists wouldn't do this. So we should actually make sure that the patient doesn't have to suffer this sort of problems. So, Bettina, moving from one end of the spectrum to the other end, and this is the older person with seizures, and this is the group nowadays in the population with a higher incidence. Which are areas where we're not doing a good enough job in this population?
Well, I completely agree. In my experience, even today, my inpatients, the majority is older than 65 years. And in most cases, these patients have neurological or neuropsychological problems already. And for these people, having seizures really means specific risks, injuries, transient TOD-like neurological problems, anxiety, depression. Status epilepticus is quite common in the elderly. There are comorbidities, polytherapies. And I think there's both the risk of overtreatment in the elderly. So many patients with acute symptomatic seizures are treated for too long, and also undertreatment. So complete seizure control and tolerability is perhaps even more relevant for older patients. Perhaps we should focus a little bit on polypharmacy in older adults. What are some simple rules we should follow?
Yeah, that's a big issue in the elderly, because once you get over a certain age, the likelihood of you taking other drugs increases. So the older you are, more drugs you will be taking. So the first important thing is that if we have to use an antiepileptic drug, we need to be absolutely sure that that's not going to be something that is going to be interacting on a big way with already drug load on board. So we need to make sure that we understand the potential pharmacokinetic profiles of drugs to avoid interactions. That is very important. At the same time, we need to remember that we need to also take into account the comorbidities, because that's the other driver for how to use drugs in this population. And this at times can be quite simple, but for other people it can be a challenge, because it's not always clear what are the comorbidities that are playing a major role and how they're going to interact with our drugs. So it's important that we always keep this in mind.
Yeah, I mean, it's always useful to check the medication plan. I mean, so many patients take more drugs than they need, so sometimes simplification is useful. But also, I think we have anti-seizure medications which are better team players in polytherapy compared to others. Yeah. So we should go for those with little interactions.
Absolutely. The drugs that do not interact would be perfect, provided they do not cause tolerability issues. And that's the sort of challenge that we need to keep in mind. So we spoke about adherence earlier on. Is this an area that we need also to have a clear view, or how should we be acting in terms of making sure that adherence is good in this population.
Yeah, I think it's a particular problem in elderly patients. Some of them don't understand complication titration schemes or they forget. So it's very important to have simple schemes, to have a good documentation, communication, perhaps to include relatives and to also communicate well with GPs and to make sure, and that's quite difficult in elderly patients, that there's a good follow-up. It's so often that we discharge patients with, a low dose of, let's say, lamotrigine and a titration scheme, and they come back after a year with the status epilepticus, and they are still on 25 milligrams. Or they come back, we put them on levetiracetam, and the family is completely stressed. The patient has changed, become aggressive and unbearable, and nobody changed the medication because the GP didn't know and the relatives didn't know that this is a typical side effect. So particularly relevant to inform about side effects and to make sure that patients are followed up.
Yeah, no, I think that is extremely important in terms of people need to know what could happen. So we can actually make sure that they come back and we can act on that.
Yeah. So with respect to safety issues, what are the biggest considerations in elderly patients?
Well, we already touched on them. One is polypharmacy, and the other one is tolerability. And of course, polypharmacy comes with different medications, and sometimes when people are using 2 or 3 different drugs, you get lost on that. So it's important that you try to consider drugs with the least potential, anti-seizure drugs with the least potential for interactions. In my opinion, it's extremely important to avoid enzyme inducers in this population because of the challenges it will provide to different parts of the system. So enzyme inducers are not really a go here, and also blockers. Enzyme blockers, not that we have many, but for instance, sodium valproate can be very hazardous in older people. It seems that older people are more sensitive. We need to also remember that some drugs can cause hyponatremia, and the hyponatremia sometimes can be made worse by other drugs they use. And hyponatremia is a big issue in terms of cognition and people becoming. So we should have a very low threshold to avoid hyponatremia and checking this. We should also make sure we avoid drugs that are gonna impacting cognition, because cognition already is a challenge in this population. Something we should have is a holistic approach. So we should support, the person in general. For instance, help with making sure that they decrease their cerebrovascular risks. Try to get people into good sort of lifestyle, diet. And this brings in the issue that this needs to be a holistic approach, multidisciplinary. We need to always involve carers and family so we can have the best to avoid risks and improve the life of this person.
Yeah, very good closing point, and it's really so relevant for especially elderly patients to stay active and despite the epilepsy, for everyone. I'm afraid our time is over. We could discuss for much longer, but I think we've mentioned the most relevant points, haven't we?
Yeah, really important to remember all these points.
So thank you very much for this discussion, Lei.
My pleasure.
And thank you for your attention, and please continue on to answer the questions that follow, and please complete the evaluation.
This program was presented by Medscape Education Global.